typically when we're imaging prostate cancer, we're using either CAT scan or MRI plus bone scan. And the problem with these imaging modalities is that they're pretty insensitive at low PSAs. So for the guys who are just starting to recur, doing these scans, we're pretty much guaranteed not to see anything. And the other problem is that bone scan in particular is an indirect way of looking for cancer. So it actually looks at the healing reaction to cancer rather than the cancer itself. So a lot of people have come up with different imaging strategies to try to improve on that. Those range from choline PET to sodium fluoride to the newly FDA-approved fluciclovine scan to PSMA scans, which are sort of the wave of the future. So a lot of these are various PET modalities that are different than the conventional PET scan that we think about. And the idea, obviously, is to pick up disease at lower levels than we were previously able to detect. The real question, though, is does that help patients, right? And so the way that we think it could help patients is if we're able to detect small amounts of disease, for example, just after a surgery, and we're thinking about planning salvage radiation to the prostate area. We might use sensitive imaging to actually guide that beam rather than radiating blindly, and we might actually include a little bit broader area than we would otherwise. Another area that it could be helpful in would be patients who have already been through all the standard local therapies, have rising PSA, don't have anything on a conventional scan. And there's a question of whether we could pick out early so-called oligometastatic recurrences and do what we call metastasis-directed therapy to those, meaning do some radiation or surgery just to selective areas of recurrent cancer. And that was tested in a trial called the STOMP trial and seemed to delay the need for systemic androgen deprivation therapy, which of course most patients hate, has a lot of toxicities, and it certainly doesn't cure the disease.